Today we want to talk about evidence to support pediatric therapy practice. These were the slides I want to move past. So we've already been introduced, so thank you for this great opportunity. Today we want to talk about bringing evidence into a therapy clinic, a pediatric therapy clinic, and the benefits of having science be incorporated or evidence be incorporated into your practice, and really why we need to be on the side of science. For many years, in fact, probably for a decade, evidence for therapies was pretty limited. The research for what we were doing tended to be a little intuitive. It tended to be anecdotal, but we don't have to remain there. We don't have to be there anymore. There now are many effective therapies that have strong research behind them, but they're slow to be adopted. They're slow to be incorporated into practice. And so therefore, there are a lot of outdated, untested therapies that still are rampant throughout our clinics and through our programs. But today we want to talk about moving past that and seeking the evidence. So,
hey,
yes.
Valerie, you might want to change your display settings so they can see the slide bigger. Right now you're on presenter view.
Oh, you know what? I think the screen that I'm looking at is not the, okay, I'm going to stop sharing my screen. Thank you. And see if I can share. I think what happened is that when I shared my screen, apologize. I need for it to, I'm having trouble transitioning between my screen 1 and screen 2. So it's looking at,
it was viewable in the format. It would have been, it'd be nicer if it was full screen, but I think it's
I think
viewable.
I might have it. Hold on. No, I apologize. I can't get it to switch over. I know what you're saying. Now you can see all I got. Okay.
Do you want me to share, Valerie? Is that helpful?
Yeah, let's see if you can share, because I can't get it to switch over to the, I can pull up the full screen, but I can't get it to switch over to the screen itself. And I thought that's what you were viewing.
Okay, can you see the full screen?
Yes.
Oh, but I'm on the wrong slide. We'll get it together. Okay, here I come.
And then just go to the next slide, Karen.
Yep.
One back.
It's still not on. Yeah, there you go.
Okay, go back one slide, I think. One more. Oh, okay. Oh, okay. All right. So why we need to be on the side of science. So there is a lot of exciting new evidence out there. The emphasis is on many, we've been able to glean a lot of information from different disciplines. One is exercise physiology. We've also been able to pull on motor learning, which we'll talk about in the next slide. These are all, we have this information available to us in our clinics. So while they're not particularly, it's not particularly studies that might be focusing on therapies, there's a lot of valuable information that we can integrate, as well as, and we can bring it into our practice. So here to the left, you will see this is actually one of our physical therapists here at UCP of Central Arizona. And she's using our 0G with a little girl. And the 0G actually incorporates all of these things. So 0G is a robotic assisted gait trainer, and it uses new technology to promote motor learning. And it's something that we did a lot of research before we purchased this for our clinic. We looked at information about what was best practices, what was the best technology out there for children. In our practice, we knew that we served under the age of 12. And so that was something that we wanted to capture when we were looking at bringing this type of technology into our clinic. And so this choice, I guess, is what I'm telling you, was based on the evidence that we had researched and then we knew at that one point. So turn to the next slide.
Sorry, now it's stuck. There we go.
So this is what I was talking about, is that we as therapies has evolved from an art or a philosophy to new techniques that can be based on scientific principles. And they do, as I referenced, do come from different disciplines. Exercise physiology, motor learning are some good examples. But what's most important, what's the key element of all of these things, is that there's active participation both by the child and also or the adult that's involved. So for example, I'm just going to give an example here with motor learning. There is an approach that has come out of some systematic reviews, have come out of the research, and it's called goal activity motor enrichment. And what that basically, or we call it GAME, so I had to look and make sure I had the acronym right. But what that does, that incorporates what we know about motor learning for a child. And we know that we need to enrich the environments and that the child needs to be an active participant. And so this particular therapeutic approach that is being used primarily with children with cerebral palsy, but all children, pulls from all of those different disciplines to be able to impact our practices. So next slide. Well, I couldn't get the right screen. Now you're stuck.
I'm working on it. There we go.
So I think as clinicians, when we're so busy, it's really hard to think about incorporating evidence. We all go to maybe some webinars or seminars, go to conferences, and we are able to sort of carve out time to be able to try to find, seek evidence. But really, in reality, it doesn't have to be that daunting. It doesn't have to be that challenging to do some of your own self-study, particularly when you're attempting to incorporate the evidence, or you're attempting to find out what that evidence is. So the first thing, a lot of us who might be just working in a clinic and we don't have any academic affiliation, there are different search engines out there that can be used when you're looking. So Google Scholar is a great example. Sometimes people are surprised that their own alma mater they're able to go back and be able to pull, get access to search engines there. Your professional association is there. But the ones that I really love and have enjoyed as well too is ResearchGate. Is a great example. It's a scientific social networking site, but they make available all sorts of articles that you might, or you can find what you're looking for. And then another one that's available too is academia.edu. You have to be careful. You might get on their email list, so you have to kind of control that. But they do prompt you when when different information that you're seeking becomes available on their site. So I think the main thing as a clinician who is seeking out evidence, I think it's really important that they remember pull back from their college days about the Boolean language, that will help them. Those and, or, nots, and the truncated words will help you be able to target and refine your research and to find the evidence that you're seeking. So next one. So another way that you can get a really quick fix on being able to get evidence, to seek the evidence, is using the word review, and you will get all sorts of reviews on the topic. Systematic reviews or over reviews of reviews are just a compilation of data that's been collected by experts. It's been analyzed to remove the bias, and it can give you what it kind of does the work for you. It goes in and looks at what is really valid, and then tells you, gives advice, which Karen's going to, not Karen, but Diane is going to go through a systematic review with you a little bit. This is a great resource for a clinician who's looking for for the best evidence. Another is clinical guidelines, which really basically what they do is they pull on those systematic reviews to develop a care plan for specific populations, and give you basically, based on the reviews, then they give you expert opinion about your clinical practice. And again, they're guidelines. So they're used to guide you and give you they're basically, they are guidelines. They're simply just that. So next slide, Karen. So one of the beautiful things too is that, I feel like this is, okay. One of the beautiful things too is that you don't always have to go search. I kind of reference this with the academia.edu, is sometimes you can have it just delivered to you in your email. And Cerebral Palsy Research Network does that beautifully. You just have to get on Cerebral Palsy Alliance's website and sign up. And it's supposed to be the Monday email, but I've noticed it comes Tuesday or Wednesday. So there are humans behind this, but it will give you an update on what is the most current or recent research around cerebral palsy. And it's a great resource that we rely on and use because sometimes it'll alert you to things out there that you did not know. All right, going into Karen, you're on. Or Karen, Diane, you're on.
Diane.
I think Karen's after.
Hi, everyone. Yes, I'm really happy to be here. I'm a researcher at NIH, as you heard, and I've really loved being part of this research committee. You know, Valerie has just been amazing. And as you can see, she's really trying to get evidence-based practice and research, you know, within UCP and basically everywhere. So I'm going to talk a little bit about, you know, the evidence that has been accumulating. And what you'll see is we've been getting lots more evidence, and the different sources of evidence are really very consistent. And it's really nice to see. In research, we use something called grade when we review the evidence. And basically grade gives something an A, B, C, D, basically how good is the evidence based on multiple factors. And this has really been made more visually with this traffic light system. And this is more of a pass, low pass, fail type of thing. And what they do here is they try to, when there's enough evidence that things have been shown to be effective, then they'll be in a green light. In that middle range where the evidence is not as great or it's not as consistent, they will give it more of a yellow light. And then the red are things that clearly there is enough evidence we should stop using this. So let's go to the next slide to see how that plays out. So this is the latest, and I know you can't see these bubbles, and I'll summarize these for you, but this is from the Novak 2020 publication that came out, and they had done this in 2013. And for those who've seen that, the bubbles are probably 3 to 5 times greater here. And we have a lot of things that have reached sort of the green bubbles, and the bigger the bubble, the greater the evidence. And then you see some things hovering near the top. They also draw something called the worth it line. There's a black line down near the bottom where the evidence really suggests that those things below the line are probably going to end up being shown to be not as effective. I do also want to point out that the bigger part is really for looking at motor interventions for older children. On the very right, you see that little sliver is about the evidence for early intervention. So you see there that our evidence in that area has not accumulated, is not as strong. Okay, next slide. So the big winners from this, these are things we should definitely be doing in our practice. The one is constraint-induced movement therapy, or also habit, which is a bilateral training on both arm and leg training. The second is more mobility training, either using partial body weight supported treadmill training or other types of overground mobility training. And the third big bubble is to use strength training. Next slide. But there's also, and interestingly, when you do the traffic lights, they were actually meant to really get people to stop doing things. That the red lights were really not just a D grade, but we want you to stop doing these. If this is your practice, these are things you should replace with the green bubbles. So neurodevelopmental therapy, sensory integration training, hyperbaric oxygen, cranial osteopathy. And then there were a few things that are used fairly often that are also below the work at line, which was conductive education and massage. Now, massage is really for older kids to reduce spasticity. It's not talking about baby or neonatal massage. Next slide. We did an evidence synthesis. They're now called overview instead of systematic reviews for early intervention because there had not been a systematic review since 2017. And in an overview, you also add any new randomized clinical trials. And so in this latest report, we just looked at motor interventions for children 0 to 3 with a high risk of CP, which really that definition varied across studies. And we had, there were 3 systematic reviews that had 22 studies, unique studies in them. And then we had 4 RCTs, 12 with comparison groups and 6 new RCTs, about 670 participants, plus 186 from the new RCTs. And we were asking the question, is there evidence yet on whether earlier is better? Next slide. What we did find here is that there were several trials, and Valerie mentioned one game that started 3 to 5 months. There were actually 3 RCTs. That suggests that earlier may be better, but right now there's a lot more RCTs underway where the protocols have been published that are going to be giving us a lot more evidence. So this is a little bit different. This is for 0 to 2 years, children 0 to 2, and this is a clinical practice guideline. Evidence is just really talking about what do the data show. Clinical practice guidelines, when there are gaps in the data, they actually also include expert opinion. So this one just shows, you can sort of see an algorithm here, but basically it's showing something very similar, that if you have CP for motor interventions, for unilateral CP, you would do intensive upper limb training. For children with bilateral CP, you do more task-specific training. You don't do passive type things to children. So this again is trying to give people out in practice what are the best guidelines for what we should be doing in this age group. Next slide. So this was also by a group in Australia that got together and actually tried to do a systematic review of interventions to improve physical function in children and young people with CP. Again, it's another international clinical practice guideline. And this is an incredible resource of all the ones out there. This really takes those traffic lights and really puts it into practice. And it discusses intervention strategies for 4 main goals: mobility, hand use, self-care, and leisure. And what they say is the best approach is to use task-specific training. That means if you want to practice walking, you practice. If you want to learn walking, you practice walking. And it has to resemble the task as closely as possible, and hopefully in an everyday context. Next slide. So these are basically taken right from this article. So what do they recommend for hand use and self-care goals? Well, it should be goal-based. So it should be a goal that the child wants to accomplish themselves, such as I want to learn to dress myself. And again, real-world settings are important. Training needs to be intensive. And so it has to at least reach 60 hours where you really start seeing clinical change. It needs to be incorporated in the home. If you do something in therapy or in a camp, constrained camp, you really need to make sure that transfers to what they're doing at home. As I said, it can be unimanual or bimanual. Some of that is related to the type of brain injury, but not necessarily. And then in children that have less functional, this is the manual ability classification system. Some children, even with training, won't be able to do things themselves. They may need assistance, other assistance or devices. Next slide. So again, what are they recommending for mobility? To increase walking speed and to increase endurance. They recommend overground training with or without a walker and these GMFCS levels, and then treadmill training or this combined upper and lower limb training habit. And I like this is again, not providing training and mobility can have bad consequences. So this is strongly recommended at all these GMFCS levels. And of course, we have to consider the child's age, their GMFCS level, and the family preferences for the and the availability of devices. Next slide. So the real challenge is getting the evidence to those who use it. And we hear this all the time that research on average takes 17 years to get into practice, whereas with social media, bad conspiracy theories or whatever can get out there within 5 minutes, it seems like. But so how do we make this better? And there's been several ways, there's several approaches to this. One is really trying to change research designs and using something called pragmatic trials. We can't afford or don't have the time to do all the RCTs. So this is really very similar to what they do in cancer now. Instead of waiting for an RCT on the next drug, they basically are following people over time and they learn in real time what's effective. They do it within regular clinical care. And then they try to bring this back to the clinic. They tweak it some more, and then evidence accumulates slowly over time. It hasn't been used a lot in CP, but it really should be used more. And then we talk about knowledge translation or knowledge mobilization. And this is really, we're trying to now engage, the researchers are trying to engage the stakeholders, and that's the parents, the patients, the insurers, the health administrators, into this dialogue of these are things that we're learning that you should be doing. And this is really trying to get knowledge into action. And then implementation science, which you'll hear a great example from Karen in a minute, is really trying to get that evidence to transform healthcare practices and policies to really make this very firmly into what we do every day. So thank you, and Karen, over to you. I think these we cut these out.
You're right.
This might
Okay.
be a version.
Sorry about that. So I am going to talk to you today about implementation science. And so this is a good example that's out in the literature right now that was done by the group at Nationwide. And what they did is they took the early detection guideline that was out by Iona Novak and colleagues, and they put that into practice in a high-risk infant clinic. And so what they showed is that by putting the guideline into practice, they were able to increase their follow-up visits. They added in some important assessments, including the HINE and the GMA. They increased their staff knowledge about why early detection and diagnosis is important. And they had improvements in the age of diagnosis and family satisfaction. And by implementing this guideline, they decreased the age of diagnosis of cerebral palsy from 18 months to 13 months. So that's a pretty great change they made just by implementing this guideline. And so today I'll talk you through another example. Of course, this is a huge project, and I'll just talk about a portion of it, but I'll talk about what that looks like. What does it mean to implement a guideline into clinical practice? So the portion that I'll talk about right now is how we put a process into place in order to monitor what the guideline calls infant detectable risks. And that's important because if we can monitor infant detectable risks from the guideline, it can lead to formal assessment through an early detection clinic, and then again lead to early diagnosis of cerebral palsy. And so if you look at the guideline, if you're familiar with that at all, within the guideline, you'll see this box, and it talks about some infant detectable risks. And so the couple that I'll talk about today are the inability to sit independently by 9 months of age, or if you have asymmetrical hand use, or if the baby has an inability to take weight through the plantar surfaces of their feet. And if you show any of these signs or infant detectable risks, then what they say is that we should then be doing formalized evaluation for these kids to kind of further investigate whether or not they either are at high risk for CP or they have CP. So these are the standardized assessments that you see in the red box here that are recommended in the guideline. And so the process that I'm going to talk through today is how we get our kids to this formal assessment process. So the goal of this portion of the project was to screen all the infants from 0 to 24 months corrected age 4 infant detectable risks from the guidelines, and they get screened if they come in for an evaluation by either an occupational therapist or a physical therapist. And so the first thing that we did, and I'll show you a picture of what this looks like on the next slide, is we developed a system in our electronic medical record to be able to screen these infants when they come in. So this is what we did. In addition to these infant detectable risks that I talked about, there's one other one that we added in the guideline that they talk about, that we should monitor motor dysfunction. And in addition to the infant detectable risk, we also added head lag. So if the kids have a head lag. So for any of the babies that come into our institution, if they're under 24 months corrected age, they get this screener. And so the clinician can easily, check boxes to kind of say, yes, they have head lag, or no, they don't have head lag. And then if they have any positive signs on the screener, then we send them for evaluation. So to put that into play, we have over 200 therapists at our institution. So we had to do a lot of education. So the first thing that we did is we provided both written instructions to the therapist, and this is an example here that you see of what that looked like, the written instruction of how to implement the screener. And then we gave a presentation at one of our staff trainings. So each time you implement an intervention, you have to check the data. And so after we implemented the education, we reviewed the data, and we had very low completion rate of the screener. So we had to figure out what the barrier was. And so anytime you implement a new process like that, it's just plainly hard to remember. So the solution is, what we did is we have a track team that works with the high-risk infants, and we reviewed schedules for every therapist at the institution and sent a reminder if they had a baby that was under 24 months of age to say, hey, remember to do the screener on this baby. We gave a specific time. I think I have an example. Oh no, we gave it a specific time. You have a Monday at 9 o'clock, so they could kind of remember to do the screener on that patient. So then we looked at the data after we did that, and we made improvements for sure, but we thought we could still do better. And so the next thing that we did is we followed up with the therapist after the appointment. We then looked at their report to see, did they complete the screening? And if they didn't, we asked them for feedback. And so that's what this looks like. We gave them the patient's name. You saw this patient. This is their MRN. This is the date of the eval. And we just asked them for some specific feedback to say, like, what got into the way? Is there something that we can help you with to make sure that this gets done on the next patient? So we just solicited feedback from the therapist. And then the last thing that we did is we put this reminder in the top of our infant eval template so that the therapist couldn't close the note without either completing the screener form or getting rid of that reminder. And so it was a nice way. I think that was, the last step that kind of brought our data up to where we wanted it to be. And I'll show you that here in a minute. So this is how we collect the data. And I know it looks really scary, but this just shows that we collected it every 2 weeks. This red line here shows you where we set our baseline. So when we started the project, we were at about 48% completion rate. So we completed the screener 48% of the time. When you have eight data points above this line here, you get to shift it up. So you can see here, we shifted up, and then we eventually got to 65%, and then currently we're about 81%. So this is just an example of how you do these short educations and these short trainings, and you look at the data to see if it's working. And so that was just a short snippet to kind of show you what implementation of a guideline might look like. And that is the end of our presentation. And now we'll take questions if you have any questions.
Okay, I'm back. Hello, everyone. Thank you for that presentation. It was great tag teaming. I'm going to take a look here at our Q&A, and we'll just start right there because we're diving straight into audience questions. If you are out there and you have a question, please go to the Q&A function there, chat box, and put that right in there, not in the general chat window. Just put it into Q&A. So first one comes from Mark Hill. It says CPADO. Wonder about deaf children's language development that often are a language depreciation, waiting until the age of 5 CP and deaf organization is concerned? Hopefully you'll understand that question. That sounds like inside baseball. Do you want to just take that, Valerie, start?
So I think the concern is that there is a wait until the age of 5 and there might be a diagnosis of both cerebral palsy. So I'm going to operate on what I think I understand it to be asking. Cerebral palsy, and then it looks like there's some hearing loss, deaf. I wonder about the deaf children's language development. Okay. So I think that it would be easy to say that waiting to 5 is too late. The research is telling us early. So if I would be concerned as well too. I don't know if this is a policy or this is a child that's known, but I would advocate for that child or that children be served as early as possible. And so even looking at children with these specific diagnoses, infancy, once you're aware, which with hearing loss is usually very early as 2 months, and hopefully cerebral palsy will be early, just as early soon. That's when intervention should occur. So I hope I answered that correctly.
And kind of feeding off of that a little bit and what you just said too, just for kind of an average parent out there who's tuning in, they're not necessarily a clinician, is the what's the earliest that conceivably the doctors would be able to detect whether a child is exhibiting any sort of symptoms of CP?
You want to take that, Diane?
Yeah, I can take that. So we think that reliably before 5 months of age, you can diagnose CP. Now, that's really in the group of kids, sort of the 50% that came sort of from the high risk neonatal category. There's other sort of a different algorithm to follow, but definitely within the first year of life, and the sooner the better. And part of that depends on how involved the child is as well, and what their history was. But going back to this, sensory is actually very early. So sensory merge is right around birth, and where we think the window for motor is about 3 to 6 months for that window of opportunity. Newborn hearing and visual screening is really critical because that's really when those skills are merging. And so as soon as possible after that, and we don't have to wait for a diagnosis of CP, right? Children can be getting different things for their different developmental issues. Like many children with CP will have multiple issues as well.
Okay, let's see. Let's go to another question. I think we're almost out of time, unfortunately, but let's go to this question. Let's see. Let me ask a question regarding the total hours of training for hand to see changes in hand function. As I read an article that includes intensive campaign for 9 days or 3 hours per day, mainly CIMT. And they mentioned that there was a significant difference after the campaign. I'll leave that to whoever wants to answer.
I can get that one. So I think we're still trying to study and trying to figure out the best dose of CIMT. There's still studies going out right now. We're involved in a multi-site study where we're comparing 6 hours a day for 4 weeks compared to 3 hours a day for 4 weeks. But we do know that beyond the hours, it has to be intensive. It has to be close to 60 hours, and it has to be in a shorter amount of time to see those changes. So I think that to answer it directly, we don't know exactly, but we know that it has to be intensive, and it has to be, around 60 hours or around that.
Okay. Okay, thank you. And actually, anyone else need to chime in on that? Okay, we'll go to the next one. And actually, we have about, I apologize, we actually have about 10 minutes, so we do have some time for questions here. My question is, while we do need a lot for early intervention, if it wasn't for that, I don't know where I would be today, but what about teen/adults with CP? I would like to more support with, oops, it skipped, daily living skills such as independent living, maybe some classes on how to deal with things. So basically, I think the question there is therapies for teens and adults. Valerie, do you want to take that?
Muted. Yeah.
Diane, do you want to take it? I can take it as well too.
No, you take it. You can take it.
We do know that the resources and the services for adults with cerebral palsy is still lacking. There's been a lot of initiatives around that because of the recognition of that. CPRN is doing a great job. For example, if I pull this question back up, it looks like that they were looking at quite a few aspects of life. And so I know that they're even creating some online, it looks like it's online fitness classes. I couldn't quite tell what the format was. But so those are becoming available. When we think about like, you know, just healthcare in general, there are not a lot of, there is not a lot of resources that like physicians that might specialize. The good news is that there are some places around our country. Gillette Children's does provide care. I think, if I understand, and I don't know the full list, there are about 5 or 6 hospitals around our nation, but that actually tells you we're a big nation. That's not a whole lot. And then you have to be lucky enough to live in that city, or you need to be able to travel. So yes, it is limited, but I think change is possible. We believe that with our initiative now, that we're able to make change, and I think that help is coming for the adult with cerebral palsy as well too.
Can you speak more generally to just to organizations like United Cerebral Palsy, which is in 30 states? We happen to have 58 affiliates, but of course there are many other large organizations with networks of their own. If someone is basically looking for help and guidance, where can they turn? What's kind of an easy way to start to find a place where they can turn?
Diane, why don't you talk to, you can talk to CPF a little bit. They've been doing.
Yeah, CPF does a lot of connecting with older people with cerebral palsy in their website. They have
with the Cerebral Palsy Foundation. Is that
Foundation.
Okay.
They have the CP resource, which is a wonderful for parents and children of all ages. And they do a lot of things connecting children. I mean, at that age, it's really about participation as you get older. You know, being with your friends. I guess the 6 F's are something also very important for us to realize that, you know, what we are trying to do, I think even very young, it seems like the children are very intensely in therapy, but the real goal is to get things into the community, making, like maintaining your fitness, make it a fun part of your life, like with everybody else. It shouldn't be therapy. And then to realize that children, you know, the communication becomes more important and social things become more important with age. And so I do think there have been more efforts thinking about those social things and the mental health issues as people age with cerebral palsy.
And I suppose the answer to this is probably yes, but should people be concerned if they go online and they'll find somebody legitimate like Cerebral Palsy Foundation and others, I think CP Alliance, very reliable, United Cerebral Palsy, but should they be concerned that there may be folks out there who are just trying to make money, and they should, you know, how do they sort of keep themselves safe from being sucked into some organization that says it's doing CP services? Valerie?
That's $1 million question. That's really a tough thing, but you know, because you know, the one thing that I notice as a scientist is that people that do more anecdotal type things are promoting things that they're much more sensationalist and much more they talk about their benefits a lot more, where science tries to be a little bit more careful and, you know, we think this will help. And so somehow it's like this is really knowledge translation that we need to communicate probably more clearly and you know, so people really understand the differences. And I think that's, again, this is the dialogue we need to be having more with families and patients.
Mm-hmm. So do your homework. I'm sorry, Valerie.
Yeah, I would also say if you're at a website and a chat box flips up at the bottom right, probably their intent is to solicit you. And I think that there are several out there looking to provide legal services. Mm-hmm. So they actually provide great information out. You know, some of the websites provide great information, but so yes, I think, and what Diane said as well too, is it. Unfortunately, we all have to be discerning customers, so, and it's tricky.
Yeah, I'm not obviously an expert like you guys, but I work in this world and I see stuff sometimes online that I realize these folks look like they're really just trying to make money. And I'm talking about stuff that's connected to CP and not necessarily trying to help you. So next question. Hello, I am 47 and have CP. We have about 5 minutes before we have to end. I'm 47, have CP, and as an MH therapist, I also work with many adults with CP. I'm curious about ongoing OT/PT for maintenance. Is there any evidence that therapies continued into adulthood can be useful? Who would like to take that?
I think that, I think that the maintenance probably is something that you would not particularly seek occupational therapy or physical therapy for maintenance. However, there are many life events that do occur. Surgery occurs, changes do happen. So, and I would venture to say that typically, while therapies is one piece of what probably you need a whole team, so whether you're a child or an adult. So what you would want to do is to really have, going back to what we talked about, like you want to be an active participant in your therapy. You want your therapies to be goal directed, and typically that's lacking in any type of maintenance program. So I think, the complexity of that is, or of that question. But I definitely think that there is evidence that validates therapies for the adult, but I think it's contingent on what the circumstances are.
Okay, and now from a mom of a 3-year-old with CP, a struggle of finding CP-based PT programs. Found many programs in my state are geared toward autism. Any suggestion on how to find a program or a guide to programs to look for that are more science-based guidelines for CP kids? So where would you point the mom of a 3-year-old CP?
Where does she live?
So go ahead, Karen, you want to start?
I was just going to say, I think I would start with talking to a pediatrician, or if you are involved in like a PM&R clinic, kind of talk about programs with them to see, what kinds of things do you want to work on, and talk about things in your area. So I think I would talk to your local clinicians or your local physicians to kind of see what they know of that might be out there. And it really depends on what you want to work on to kind of see where to go with that.
Diane, you had something to add?
I was just asking where she lives. We have, the American Academy of Cerebral Palsy in developmental medicine has a network of professionals. So like, even if we don't, like if someone writes to me and says, where in my location can I find practitioners? We actually have something we can go to and look for members in that area. So we'd be happy to help her if we knew where she lived.
Okay. Yeah, perhaps she could post that as well. So we're going to wrap up now. I just wanted to, first of all, thank our panelists, of course. Thank you so much. I want to let people know that United Cerebral Palsy has launched its research initiative. And so part of that is a pilot grant program, which Valerie helped design and is kind of running basically. So look to our website if you need information about the pilot grant program, if you're out there and you're doing research, including if you're doing research and you're connected to a UCP affiliate as well. In addition to that, we will be posting all of these individual videos online after, and everybody who's registered will be notified about where those are. And then if you want to try to reach any of our panelists, you can contact me. You can get to me through your Eventbrite link, and I will try to pass along information if there's something that they can respond to you on more directly. And then I will check with finally our panelists on whether or not we can distribute the slideshow that was presented to the viewers as well. Sorry, we did not get to.
I'd like to add too, we have mentioned a lot of resources, so I'll provide those to you.
It'd be great.
For both children and adults, so that they can even be distributed. I know we've referenced the AACPDM, we've referenced some care pathways, we can do that. And I think it's important to remember that UCP themselves provides great services out in the community as well too. So they too can be resources for some of these individuals that are writing in. Absolutely. So we'll get you as much information if you're registered, and we have your email and we can respond to you, and we will not bombard you with ads or anything like that. We will relay any information that we have that we think is useful to you. So thank you all for being on. I want to thank our presenters,
By the way, as mentioned in the video, we also have a quarterly professional learning series of webinars. You can find out information about that on our website. We have experts who come on and talk about these issues in detail. Now we're going to take a short break, and we're going to come back at 1:20 p.m. Eastern time. That's 10:20 Pacific, at which point we will get to hear from our keynote speaker for today, the actor and disability advocate and honorary board member of United Cerebral Palsy, R.J. Mitty. So ladies and gentlemen, thank you for coming. Please enjoy your break, and we'll be back in just a little under 15 minutes. We're coming back at 1:20 p.m. Eastern. Thank you so much.